Okay, coming to the cardiac inspection, palpation, and auscultation. Comparatively, this is a simpler topic. This is not so difficult and all. Comparatively, relatively simpler. So we can finish reasonably faster. So, I mean, I've told you about the different scars here. So first of all, in inspection, the most common thing that you miss out is scars. Okay. Very, very important. In cardiac inspection or respiratory inspection, whatever it is, the understanding of scars is of paramount importance, because even in modern era, seeing the scar itself, even the patient doesn't say anything, seeing the scar will say what type of disease the patient had. Most of the times, patient will not show anything to me. Many times I've seen this. They'll just come, they'll say, I have cold in the OPD. I want a COVID test done. So this is how they come. But just for auscultation, I'll ask them to open the shirt. I can see a central midline scar. I'll ask, yes, doctor, 10 years munadi, bypass, they did. They say it. It's very, very commonly it happens. So that's why I'm saying, even in the modern medicine, in the modern era, the evaluation of scars still plays a role. So patient may not tell, you need to understand. So what's going on? So a lot of scars are there. Different scars are there. I've given this. Maybe you can take a photo of, because I cannot discuss each and everything, you can take a photo of this, or probably, you can memorize this virtually also. But I would say the central midline scar is going to be extremely important. Okay, the midline central scar is very important, because that median sternotomy scar will say multiple things. So the most important is valve replacement surgery. Okay, median sternotomy scar, valve replacement surgery. Apart from that, it also says that the patient may have had a bypass surgery, coronary artery bypass grafting, CABG. Clear not? So it can say a lot of things. Similarly, a scar in the lateral area, the lateral thoracotomy. Okay, it can also tell a lot of things. Again, a mitral valve surgery. So generally, previously, that open mitral valvotomies and all, they tend to do by lateral thoracotomy only. So multiple things at multiple places. So you need to look at the scars very carefully. And if I am the examiner, I'll be asking you about the significance of each and every scar that you see in practice. Okay, because each and everything has some value. If a patient had some congenital heart disease also, that has a value. Because for congenital heart disease, you're going to perform a lot of procedures are there. And the location of the scar again can give you a clue in what type of procedure that the patient would have gone if it's a congenital heart disease. So that's why this becomes a lot important, inspection. Okay, so what are things you will see on inspection? She is the presenter. What are things you will see on inspection? Okay, when you talk about inspection, number one is JVP, as I've told you. Very obviously visible things. JVP. Suppose, remember, if there is no scar, maybe because it's a negative point, you can say at the end. But if there is a scar, you have to comment immediately. This practice will help you not to miss this. That's why. Am I right or wrong? Because you keep the scars at the last, you often forget. Because you concentrate on other things like apical impulse and all. Keep the scars a second point itself, or the first point after JVP. So you will never forget. Maybe if there are no scars, maybe you can say at the end. But if there is a scar, make it a practice that you say after JVP itself, because it's a very obvious thing. Even more than the apical impulse, at least you need to look carefully. But scars are very obvious to your eyes. So tell the most obvious thing. You have a scar there, midline sternotomy or lateral thoracotomy scar. Some kind of scar is going on. Okay, then what else? Pardon? Okay, tracheal portion. So, okay, fine. That's okay. But tracheal portion is more important for respiratory issues. But that's fine. That's okay. You can say tracheal portion, not a problem. Then apical impulse. Before that, structural deformity. Once again, say the most obvious things first. Always. That always is very important. Apical impulse is something that you look for, but obvious things first. If there is a kyphosis, scoliosis, pectus, excavatum, or pectus carinatum, that's going to be very, very obvious. So say that first. Then you can put everything together as cardiac pulsations. Okay, cardiac pulsations. There is a wide group of pulsations called as cardiac pulsations. So cardiac pulsations can be anything. So it could be apical impulse. It could be parasternal pulsations. Okay, parasternal pulsations, we commonly called as parasternal heaving, but it could be visible also, your parasternal pulsations. Okay, we have something called mid-precordial pulsations. And you have precordial retractions. Precordial retractions. Okay, so these are basically cardiac pulsations. What are the reasons for that? So remember, apical impulse, please understand, generally it is by the left ventricle, formed by the left ventricle, but it can be what? Right ventricle also. So don't comment on LV apex or RV apex unless until you're dealing with a congenital heart disease. Okay, in an adult non-congenital heart disease, apex is always LV only. So if you're dealing with the congenital heart disease, then definitely you need to comment whether it's a left ventricular apex or a right ventricular apex, because based on whether it's a LV apex or RV apex itself, you have a variety of differential diagnosis. So I'll talk about that later on. So LV is the most important. Okay, then we have parasternal pulsations. As I told you, parasternal pulsations, where will you hear parasternal pulsations? Typically in the left, third, and fourth intercostal space in the parasternal area. That's the characteristic location of parasternal pulsations. Usually, parasternal pulsations will be due to right ventricle. If it's a hypertrophy especially, you will be able to see the parasternal pulsations. It will be in the left, maybe you can say third to fifth intercostal space, generally in the parasternal area, immediately next to the sternum. Then what are the conditions that produces mid-precordial pulsations? Typically, you will see in the left, third, and fourth intercostal space, but in the mid-clavicular line. That is called as mid-precordial pulsations. And this is usually due to LV aneurysm or aneurysmal dilatation of left ventricle. Mid-precordial pulsations have been described in LV aneurysm. Then finally, you have something called as precordial retractions. This kind of entire precordium retracting inside can happen in constrictive pericarditis or in patients with extremely severe tricuspid regurgitation. Because in tricuspid regurgitation, instead of blood moving into the pulmonary artery, it is moving into the right atrium. So the right ventricle tries to go inward. So the entire precordium appears retracting inside. But very commonly, it's a constrictive pericarditis. Whenever they talk about precordial retractions, means you have to talk about long-standing chronic constrictive pericarditis because of the fibrous pericardium that is retracting the chest inward with each contraction. That retracting precordium with each beat in patients with constrictive pericarditis is also referred to as Brock sign, B-R-O-C-K. Okay, that's also called as Brock, B-R-O-C-K, Brock sign. Apart from the cardiac pulsations, what are the other things that you're going to look for? You're going to look for arterial pulsation. Arterial pulsation. Okay, arterial pulsations could be due to either aorta or it could be pulmonary artery pulsation. So where you will see aortic pulsations and where you will see pulmonary artery pulsations. Generally, in the left second intercostal space, little close to the sternum, that is the location where you see the pulmonary artery pulsation. We all know that. Third to fifth, I told you for right ventricle, parasternal pulsations. Second intercostal space is for pulmonary artery pulsation because it's a pulmonary area, as we all know. Where you look at the aortic pulsations, right upper sternal area, we call it as right upper sternal border, or simply right second intercostal space immediately next to the sternum, or right parasternal area in the second intercostal space. You can call it in any way, or simply you can call it as right upper sternal border. Or alternatively, you can look out in the right sternoclavicular joint, SCJ, sternoclavicular joint. So this is to look for pulmonary artery pulsations. This is to look for aortic pulsations. Especially in aneurysmal dilatations of aorta, you might have pulsations here. So then, if these are additional things, if you want, you have to comment on chest wall pulsations also. Chest wall pulsations. For example, if you see a tortuous chest wall underneath the scapula, tortuous blood vessels running underneath the scapula or running in the lateral area of the ribs, what do you suspect? Coarctation of aorta, because these are collaterals of aortic coarctation, especially underneath the scapula or in the lateral chest wall near the ribs. So if you see in those areas, that might indicate a coarctation of aorta. And you have to look at the neck also. Not just for the JVP, because neck veins may be distended in patients with SVC obstruction. And there could be puffiness and edema, cyanosis and all in the neck. So you have to look at the neck also. Apart from that, if you want to say, not just in the general examination, here also, you can look for markers of congenital heart disease. I mean, if depending on your local policies again, where they want you to mention, you can mention accordingly. If they ask you to mention in the general examination, you can mention there. If they ask you to mention in the CV cardiovascular examination, you can inspection, then you can mention there also. Then you have to comment on the markers of atherosclerosis, and you can comment on the markers of infective endocarditis. And some people ask about rheumatic fever and all. I don't feel that is logical anyways. So markers of congenital heart disease, markers of atherosclerosis, markers of infective endocarditis, and markers of rheumatic fever. So markers of CHD we have discussed extensively already. And what about markers of atherosclerosis? Okay, usually your xanthelasmas. Okay, sometimes xanthelasmas may be congenital. Even without dyslipidemias, you can get xanthelasmas. So don't think like all xanthelasmas are abnormal. Only in patients with very high LDL, very much deranged lipid profile, if there is a xanthelasma, you should be worried of. I've seen a lot of patients with xanthelasma which runs in the family. And LDL will be just 60 or 70. Will be very normal, nothing to worry about that or bother. And we have something called corneal arcus, especially if it happens in the younger age group. That's called arcus juvenilis. Then there are two types of baldness, okay, which actually thought to increase the risk of coronary artery disease. One is called as frontoparietal baldness. Frontoparietal baldness. Second one is called as crown top baldness. And there is another sign called Frank sign. You know what is that? That's called earlobe crease. I don't know how many of you have heard about that. There will be a small crease running near the root of the ear. That is called earlobe crease, and that's called as Frank sign. We really don't know the sensitivity, specificity, positive predictive value, and negative predictive value of these signs for sure. But still, they have been described as one of the important signs of atherosclerosis. And even nicotine staining is something that you can look for if you want, because that again indicates the patient is a heavy smoker, right? So which can tell that the patient might have atherosclerosis. And what are the markers of infective endocarditis? I mean, these again are not external markers, but still, I don't like it because, I mean, the patient's profile will be completely different, obviously, in that situation. So what are you going to look for? Number one is that Janeway lesions. and oscular nodes. Number 3, splinter hemorrhages in the nails. Number 4 is subconjunctival hemorrhage can happen in patients with infected endocarditis. Not just splinter hemorrhages in the nail, it could be subconjunctival hemorrhage in the eyes also. And finally, last but not the least, if you think that fundoscopy comes under inspection, you can say rod spots also. Again, it depends on your local policies. So if your examiner feels that fundoscopy comes under inspection, I don't think so generally, but if some people might feel that it's an inspectory finding, then rod spots also will be added up. See, to avoid ambiguity only, many Western countries, if you see they have modified the exams. How they have modified the exams is, it's not system-wise examination, because you don't know which system the patient is having a problem. So that is the reason why they made the clinical examination as regional. For example, head and neck means you need to assess everything in the head and neck. It's not just the cardiac related head and neck examination or respiratory related head and neck. Everything. You have to examine cranial nerves. You have to examine for the external signs, look for the fundus, conjunctiva, pallor, cyanosis, everything related to the head and neck, hair, like everything, whatever you want, you need to see. So that gives a kind of integrated approach. So you will not miss out on anything. Our exam techniques are very confusing. So in what system, what to examine? So some people will say something, another one will say another thing. So it's not standardized. So that is why most of the Western patterns, if you go to MLE or whatever exam pattern you do, Western countries have adopted more a regional pattern. That's why OSCEs are very important for them. Hand examination is an OSCE. Head and neck examination is an OSCE. Just chest and abdomen examination is an OSCE for them. So in chest and abdominal examination, you do not see anything else, but you should not miss anything on chest. So that gives a kind of orientation. So which part you need to look for what? So our pattern of examination becomes difficult because you look at the chest, suddenly you look at the eyes and come back to the chest again, go to the fingers and then go to the toes and come back to the genitals and come back to the chest again. So this is very confusing and there is a lot of chance that you will miss out on something. So that's why you have to standardize. So this pattern is something that's about to change and it will change. And what about your rheumatic fever? Is there any markers of rheumatic fever? If you want to say about external markers of rheumatic fever, your chorea may be an external marker. And your arthritis in the form of joint effusion, joint swelling. So you cannot say pain, tender, but you can say comment on the joint swelling as arthritis. Then your erythema marginatum, if it is present. Erythema marginatum, it's a characteristic rash, isn't it? So of rheumatic fever. So if any one of this is there, probably you can comment as a marker of rheumatic fever. And one more important thing that you need to look for in any patient with cardiac disease is the track marks. Okay, track marks. Maybe these track marks I can write in the infected endocarditis itself. What is track marks? What are track marks? Marks of recurrent IV drug abuse. Those are called as track marks. And you can write separately or you can write under infected endocarditis examination also. Because ultimately using track marks, you're going to find out sepsis and infected endocarditis only. That's what we're trying to look for. So you can write under there itself. So this is something that's not given in most Indian textbooks, but it's very important and valid also. Okay, you are looked out on so many things. Okay, inspection wise. Then what about palpation? Inspection is done. Now, let us move on to the palpation. Remember, our hand and fingers will not be able to pick up low frequency vibrations. Anything less than 5 Hertz, we are not sensitive to pick up low frequency vibrations. But anything that is higher in frequency, our hands will be able to pick up. That is the reason why majority of the heart sounds being higher frequency. 90% of the heart sounds are higher frequency only, more than 90%. So our hands will be able to pick up. And which area to look for what sounds are very important as well. I think I had a picture on that. Let me try to show you if I have it. This is one of my favorite images actually. It was published in Springer actually a while ago. In Springer it was published in 1993, I guess. It's one of my very, very favorite images. So in what location, what all can be palpated? For example, for all localized pulsations, you're going to use the tip of the fingers for any localized pulsation. And for thrills, you have to use the metacarpal area, the head of the metacarpals. That area you need to pick up. Okay, this is the area of head of the metacarpals of the hand. So that is the area you are going to choose for looking at the thrills. And heaves and lifts, it's better to look at your wrist area, near the wrist, that is where you are going to look at. So that is the area to look for heaves and lifts. Or alternatively, for looking at the heaves and lifts, some books will suggest you to use the ulnar border of the palm also. Okay, this is the ulnar border of the palm. So even this area you can use, but technically speaking, most of the historical textbooks mention for lifts and heaves, you need to use the palm area that is very close to the wrist. So that's the area that should be recommended. Clear not? So whenever you talk about palpation, so what is the first thing you need to comment on? In inspection, there will be so many obvious things, but in palpation, the first obvious thing is the apical impulse. Isn't it? That's the most obvious thing. So that is why first you need to comment on the apical impulse. Even though you can comment on the tracheal position, but in a cardiac case, I would not recommend to start with tracheal position. I mean, but examiner, it's a very trivial information. Examiner is not looking for it. Whether you say or not, it doesn't care really. So first of all, you need to know about the apical impulse. So what is the definition first? What is the definition of apical impulse? The lowermost, outermost, definitive cardiac pulsation. This is the definition from the first year physiology. Lowermost, outermost, and definitive cardiac pulsation is what we refer to as apical impulse. And what is the reason for apical impulse? You know that there is an apical impulse. What is the reason for apical impulse? There are multiple theories actually for apical impulse, to be honest. There are angiographic correlations, mechanical theories, physical force theories. So many theories have come and all are speculations only. And what evidence right now we have is what I'm going to say for the apical impulse based on the experimental evidences. So you know heart is actually contracting during systole. That is muscle shortening, which means heart is actually becoming short. Then how it hits your chest? That is the $1 million question, isn't it? Heart is actually shortening during systole, but you get a beat outside. Ideally, during diastole only it should come and hit, no? Technically speaking, that time only you should see the apical impulse. But systole is the one that produces apical impulse, as we all know. How is it possible? It's because of the movement of the heart itself. Because heart is attached very loosely in the chest wall, in the chest, and it's not very much attached to the chest wall, to be honest. So whenever there is an ejection force that is happening, that creates a sort of momentum within the heart. Isn't it? Like, for example, you can call it as inertia also. Like, for example, when you're sitting in a bike and you're suddenly racing, what will happen? You move back. Similarly, suddenly if you brake, what happens? You move forward. So these kind of inertial changes, when the blood is suddenly moving, that momentum is actually rotating the heart a little anterior and towards the left. And that is the reason why heart is actually coming and mechanically hitting on the chest wall. And that is what you are seeing as a apical impulse. So this is what the current idea is. And one more interesting approach they have given is, I mean, before that, in cadaveric angiograms, they looked at the relative positions of the heart, and everyone knows that the right ventricle is the most anterior. So once upon a time, some people thought that right ventricle is causing the apical impulse, because technically speaking, right ventricle is the most anterior chamber of the heart and left ventricle is little behind. So technically speaking, your right ventricle should be the reason for apical impulse according to cadaveric angiograms. But later on, it's been subsequently proved that the apical impulse, even though it's located anteriorly and right ventricle is the most anterior chamber, but at the same time, the normal location of apical impulse is 2 to 3 centimeters lateral to the right ventricle, which is very close to the left ventricle actually, when you say relative information. So later on, multiple studies confirmed that the apical impulse is formed by the left ventricle only and not the right ventricle. And another theory that is given by an Indian, I forgot his name, that is physical theory. So again, the same momentum related explanation only, but how the heart rotates is what they said. For example, if you have a hose pipe again, let us assume a pipe is there that is coiled and you connect it to a tab, a big tab of appropriate size, and suddenly you open the tab. What happens? The pipe will uncoil itself. I will notice this most of the time. The same theory, as the blood is moving into the aorta because of ejection, that momentum itself is relatively changing the positions of structures within the mediastinum. And that momentum is creating the heart to rotate. That uncoiling is happening, it seems. Likewise. So that is what is causing the heart to come and hit on the chest wall, causing the apical impulse. There are multiple theories for the same. We will not worry about that. And at the same time, the heart is having two types of fibers. Okay, if you take the heart really, it has two types of fibers. One is called as circular fibers. This is the left ventricle I am talking about. This is called circular fibers. And then we have spiral fibers in the apex. Spiral fibers in the apex. And the relative duration of contraction or the relative strength of contraction of these two fibers will determine how long the apical impulse is going to sustain or it's not going to sustain. So what happens in a normal apical impulse is it's relatively not that much sustained. It will be there for less than 50% of the systole. I'll talk about that. That is the normal number. It will not be sustained for long. That is because the circular fibers are contracting and trying to rotate the heart, and that is what is coming and hitting on a chest wall. And your apical fibers that is present in the apex are spiral fibers, and they're trying to retract the heart inside towards the posterior direction. So which means the relative balance will determine how much you are going to get the force of the apical impulse, how much force the apical impulse is going to be. Suppose in concentric left ventricular hypertrophies. So you take a concentric LVH. What is concentric LVH? In LVOT obstructions, there will be a concentric LVH where the entire area of the ventricle will be thickened. The whole ventricle will be uniformly thickened, unlike HOCM where it is a eccentric hypertrophy, that is asymmetric septal hypertrophy. In any concentric hypertrophies like AS or hypertension, it will be thickened uniformly. So in that situation, what happens is the spiral fibers will be more replaced by this more circular fibers because of concentric hypertrophy. And what will happen is that retractile force away from the chest wall will not be there. So what will happen in that situation? Your hitting will be consistent for a longer period of time because there are no much spiral fibers to retract the apex into the chest wall. So that is the reason why you get heaving type of apical impulse. Are you understanding or not? So these are the some important principles based on the internal anatomy of the heart itself. That is, again, the nature of apical impulse will be determined by this kind of fibers also, whether it's heaving or hyperdynamic or tapping, all these things. We'll talk about that in a while. This is the principle. And what is the method? Now you know apical impulse. What method you will use? Remember, you can use two methods. One is supine method. You can use the patient in supine position, or you can prefer a left lateral position. And understand that there are multiple variations in the technique. But if you want to choose one method, always choose a left lateral position. That is the best method because almost 50% of the adults over 50 years of age will have an imperceptible apical impulse in supine position. It will become obvious only in the left lateral position. So that is why, especially when you are dealing with an elderly patient, always ask the patient to move toward, turn towards the left side and then examine the apical impulse. This is very, very important in exams. If you are examining supine position, all right, but simultaneously ask the patient to go to the left side also and examine. because that's the best position to look for the apical impulse. And apart from that, there are some variations in this also. Some Western authors have suggested if you are elevating the head end in a semi-recumbent position by 30 degrees, same left lateral, but if you push an additional 30-degree elevation, if you give to the chest, apical impulse is even more palpable easily. This is another modification. I say like additional 30-degree elevation, if you give to the chest, it can be even more easily palpable. And what is the timing of the apical impulse? Timing of the apical impulse. Timing generally your first heart sound will start. That must be our ventricular systole will start first, then followed by the apical impulse. Okay, then only your first heart sound will come. Then only your carotid upstroke will happen. This is the sequence. First, the mechanical event, ventricular systole will start. And even before that, electrical event will start. The QRS will come even before the mechanical event. That is different. But from clinical point of view, first systole, then the apical impulse, then the first heart sound, then you get the carotid upstroke. And apical impulse, whether it continues beyond the carotid upstroke or not. Actually, apical impulse continues over the carotid upstroke and it ends just before second heart sound. So apical impulse will continue over the carotid upstroke, which means it's not just going to stop before the S1, it's going to persist through the carotid upstroke itself. That is why I said apex and carotid will be almost simultaneous. If there is any apicocarotid delay, you need to suspect a LVOT obstruction, especially aortic stenosis. Do you understand or not? Okay, fine. So timing is very important. And at the same time, some people use the term point of maximal impulse, okay, PMI, and this term should be avoided. You should not use the term point of maximal pulsation or point of maximal impulse. The reason is because in the chest wall, point of maximal impulse could be a parasternal heave. Point of maximal impulse could be some other pulsation, like aortic aneurysm or pulmonary aneurysm. So that could not be the apical impulse. So apical impulse is unique and it's well defined. And don't use any other term apart from the term apical impulse. And what are the abnormal apical impulses? And what is the location basically? Location of the apical impulse. What is the normal location? Okay, left fifth intercostal space, normal location. There are multiple definitions. It should be half an inch medial to mid-clavicular line. Or alternatively, we can say it should be palpable within 10 centimeter from the mid-sternal line. Mid-sternal line. It should be palpable within 10 centimeter from the mid-sternal line. In the left fifth intercostal space only, but it should be palpable within 10 centimeter from the mid-sternal line. Why that point is important? Because if it's palpable beyond 10 centimeters from the mid-sternal line, you can call it as left ventricular hypertrophy. That's why that point is also important. And the area of apical impulse. Area of apical impulse is also important. It should be approximately 2.5 to 3 centimeter area, which means it should not be palpable more than that or less than that. 2.5 to 3 centimeter area, diameter of around 2.5 to 3 centimeter, which is approximately equal to 2 finger breadths. Or alternatively, even in simplest form, it's approximately equal to 1 intercostal space, not more than that. Okay, vertically over 1 intercostal space only you will be able to look at. What will be the normal apical impulse amplitude? Normal apical impulse will be small. Okay, small in amplitude. And brief duration. Brief duration, technically less than 50% of the systole. It should not go beyond the 50% of the systole. and it should be palpable in the above said location, whatever location I said. So very small in amplitude, and it should be very brief in duration, technically less than 50% of the systole. Okay, this is how you describe the apical impulse. You need to know the definition, method, timing, location, and how will be the normal apical impulse, and what will be the area covered by the normal apical impulse. Now going on to the abnormal apical impulses. There are multiple types of abnormal apical impulse. We can call it as hyperdynamic or hyperkinetic apical impulse, hyperdynamic or hyperkinetic apical impulse. Then you have a hypokinetic apical impulse. Then you have a sustained apical impulse, which is usually synonymous with heaving type of apical impulse. Even though some people say sustained is different from heaving, but generally in exams you can use synonymously with heaving type of apical impulse. So where you will get the hyperdynamic apical impulse, especially in patients who are having volume overload without hypertrophy. Patient is having a volume overload state, but without significant left ventricular hypertrophy, you can encounter a hyperkinetic apical impulse. Because what happens in volume overload state, if you ask the pathophysiology, there will be increased LV contractile force. Increase LV contractile force, so that you will be able to see that's hitting you a little hard. So which means here, the duration will be variable. Okay, duration will be technically 1/3 to 2/3 of the systole. It will not be more than that. 1/3 to 2/3 of the systole, technically speaking, which means the duration can be normal also, like obviously in a normal apical impulse, but amplitude will be large because of the vigorous ventricular contraction. I mean, all these things, there is no need, it cannot be quantified because these are perceptions. I don't know how to quantify this. There are so many things you can quantify, but these are examiner's own perceptions. But amplitude will be large, but duration can be normal, like normal apical impulse also, but it's just that hitting you harder, that's all. Hyperdynamic states, which is going to, which is because of volume overload states, and it is going to increase the LV contraction. That is the reason for this. And what are the hyperdynamic states that you know? I mean, any thing which I've told you yesterday, pregnancy, beriberi, all these things can cause this. Apart from that, MR, VSD, AR, okay, all these things are considered to be hyperdynamic states. And even PDA, patent ductus arteriosus, all these are associated with LV volume overload, as I told you already. Remember, in MR and VSD, pulse pressure will be normal, but still the ventricle is hyperdynamic only. Why the pulse pressure is normal? Because ventricle has 2 outlets for pushing the blood. So that's why ventricle will be hyperdynamic, but the pulse pressure in MR and VSD will be normal only. Okay. So PDA, another example. These are some characteristic examples of hyperdynamic apical impulse. What about hypokinetic impulse? Here, the ventricle is not contracting properly at all. Usually it is due to reduced stroke volume. Whenever there is reduced stroke volume, you are going to result in hypokinetic apical impulse. Classically, you will see this kind of hypokinetic apical impulse in acute myocardial infarction or patients who are having dilated cardiomyopathies. Okay, so these group of patients generally tend to have hypokinetic apical impulse. There is no proper definition for hypokinetic apical impulse. Once again, it will be less, definitely it will be less than 50% of the systole only, but it will be of extremely small amplitude. And some books will say less than 1/3 of systole. I don't really know so how to define it, but these are all only things that can be perceived. You cannot explain it easily. So, and some books say less than 1/3 of the systole. That's also correct. Okay, but very, very small amplitude compared to even normal apical impulse. And one special type of hypokinetic apical impulse is there that is called tapping apical impulse. This should be commented in patients with mitral stenosis. That's called tapping apical impulse. Then we have a sustained or a heaving apical impulse. It's a kind of forceful thrust. So this is typically due to significant left ventricular hypertrophy, especially a concentric hypertrophy, can produce this kind of sustained or a heaving apical impulse. Usually, it is due to left ventricular outflow tract obstruction. Where you can get left ventricular outflow tract obstruction? Typically in a patient who's having AS, or patient who's having a HOCM, or in patients who are having a severe systemic hypertension for a long time, which can cause significant LVH because of increase in the afterload. AS and severe hypertension, both is going to increase the afterload only. So definitely you are going to have significant LVH in this situation. So it is technically defined as one that lasts more than 2/3 of the systole. And once again, it will be having a large amplitude. So more than the large amplitude, it is sustained in nature. That is very important. So it's not the large amplitude that's important here. It's the sustained nature that persistently hitting your hand for a relatively longer time. That is more important than the large amplitude itself. Clear? Okay. So these are the three important different types of apical impulse, abnormal apical impulses: hyperkinetic, hypokinetic, and sustained or heaving. Based on the apical impulse, can you define left ventricular hypertrophy? So what are the definitions of LVH based on apical impulse itself? As I told you one definition already, if the apical impulse is beyond 10 centimeters from the mid-sternal line, that's the first definition. More than 10 centimeters from the mid-sternal line. Or if apical impulse is beyond the mid-clavicular line in supine position. In left lateral position, it can come up to the mid-clavicular line, because when you are in left lateral position, heart may slightly move towards the left. So it can come up to the mid-clavicular line also. But in supine position, if your apical impulse is beyond the mid-clavicular line, definitely that is abnormal. If the apical impulse is palpable, what is the normal area I said? 2.5 to 3 centimeters. So if it's palpable beyond 3 centimeters or more than or equal to more than 2 finger breadths. Finger breadths or in more than one intercostal space. So all these things will tell you that the patient is having a LVH. Just by palpating the apical impulse, you will be able to say. And among all this apical impulse that is palpable for more than 3 centimeters is considered to be highly sensitive and specific. If you are looking for, it's very highly sensitive, considered to be 92% specific, 92% sensitive, 95% specific, with a positive predictive value of 94% and negative predictive value of almost 97%. So that's why this is the most important number. I mean, if you ask as a modern practitioner, I would say that, because that has the highest sensitivity and specificity among all the other cutoff that you see. And there are some other causes are there. For example, apical impulse may be displaced to the left. Okay, apical impulse may be displaced to the left, but no left ventricular hypertrophy. So what are the conditions? Displaced apical impulse to the left, but no left ventricular hypertrophy. One is abnormalities of the chest itself. Pectus carinatum. Sorry, pectus excavatum, not carinatum. Pectus excavatum, where there is a depression in the chest, so the heart has to move to the left. Second, there is something called straight back syndrome, SBS. Straight back syndrome means the spine, normally there will be a thoracic curvature that will be lost. Okay, you know, normally itself thoracic kyphosis should be there. That is the backward bending. That should be there. But if that is not the case, it becomes straight means then there will be no space for the mediastinal structures to sit properly. So it will be crowded, and in that situation, heart may be slightly displaced to the left. That's called straight back syndrome. Then again, scoliosis. Of course, that is because the bending of the spine pushes the heart towards left. Then enlarged right ventricle. Okay, enlarged right ventricle may push the left ventricle towards the left side. So that's another cause. Finally, there is one cause called congenital absence of pericardium. Congenital absence of pericardium. So these are the conditions where you can see the apical impulse towards left, but there will be no left ventricular hypertrophy itself. And then there are causes of imperceptible apical impulse. imperceptible apical impulse, which means you are not able to palpate apical impulse. The single most important cause is obesity. Even cardiologists will struggle to look at the echocardiogram itself in patients who are very obese. You will not get the echo window itself. Then how will you get the window for palpating the apical impulse? So ideally, very thin patients, easily you can palpate, but very obese patients, many times, especially females, it's very difficult because the breast tissue also adding on to the worse. Very obese female with big breasts, difficult to palpate. It's not at all easy. Even you will not get the echo window itself. I'm telling you. Echo itself you can't do in many situations, such an obese ladies. So this is practically not possible. Then in patients with emphysema, where lungs will be covering the heart and the apical impulse. You would have studied tubular heart, isn't it? Because of lungs overlapping on the heart. You'll not be able to look. Or if fluid is over the heart, pericardial effusion. So what is Beck's triad of tamponade? Elevated JVP, hypotension, and muffled heart sounds or distant heart sounds. So if your heart sounds cannot be heard, then how can apical impulse be palpated? So pericardial effusion. Constrictive pericarditis, the rigid pericardium will not transmit any pulsations outside. If there is a massive left-sided pleural effusion, either that may cover over the heart or it might push the heart towards the right side, where on the left side you may not be, massive right-sided pleural effusion, Massive right-sided pleural effusions may push the heart towards the more lefter side. So in the sense, like apical impulse will be pushed more left, mediastinal shift because of that. And then you have dextrocardia. Dextrocardia, where the apical impulse will be on the right side and not on the left side. So it may be completely imperceptible. And even for that matter, not only right side, even left side pleural effusions may make apical impulse imperceptible because the heart will be pushed to the right side, like dextrocardia. I mean, not like dextrocardia, of course, but heart will be pushed laterally more towards the right side. So these are some of the important causes of imperceptible apical impulse. Okay. So whenever you talk about apical impulse, all these things are very important because they will ask each and every question on apical impulse. Then coming to parasternal pulsations, or maybe I can say right ventricular impulse. Right ventricular impulse, or simply you can say parasternal pulsations. So this is the way to look for the right ventricular pulsations. There are three different ways to look for. So one is using the ulnar border of the palm, as I told you already, in the parasternal area. Okay, so this is one way. Second way is called finger method. So we are going to palpate the right ventricle in the third, fourth, and fifth intercostal space using these three fingers. Okay, using these three fingers, you are going to palpate the third, fourth, and fifth intercostal space, that is left lower sternal border. Exactly, you keep these three fingers in the intercostal spaces and try to see the right ventricular impulse. The third method is epigastric method. So where you try to feel the right ventricle from underneath the xiphoid process. Okay, because an enlarged right ventricle definitely will produce pulsation in that area. So that's called as epigastric pulsations. Do you understand? And there is a difference between whether it's an aortic pulsation or right ventricular hypertrophy pulsation. So that's a simple technique. So when you insinuate your hand underneath the xiphoid process, right ventricle being a superior structure, it's coming from the top and it's going to hitting your tip of the finger. Whereas aorta being on the down, being on the posterior area to your finger, it will hit your pulp. So if your pulsation is predominantly on the pulp, then it's very likely to be aortic pulsation. If your pulsation is predominantly on the finger, tip of the finger, then it's very likely to be RV pulsation. So you are going to insinuate the finger like this, not like this and all. So just press and insinuate in a more superior direction. So when you're going to push in a more superior direction, like what is doing here in this image, you might be able to see RV impulse if it hits your tip of the finger. Do you understand? So that's another way to look at the right ventricular impulse. Once again, right ventricular impulse also can be hyperkinetic or heaving. Right ventricular impulse itself can be hyperkinetic as well as heaving, sustained. So where you will see hyperkinetic apical impulse in pace, like how left ventricle you are going to say for the right ventricle. So it's volume overload. So what are the conditions that produce volume overload of the right ventricle? First is ASD. That's what you should say. Number one. That's the number one condition that produces significant volume overload to the right ventricle. Please don't say VSD here. I told you VSD is not going to produce volume overload of the right ventricle. In VSD, the blood uses right ventricle as a conduit to go into the pulmonary circulation. Because in VSD, both left ventricle and right ventricle are contracting together at the time the blood is moving into the right ventricle. So it's not a condition that produces RV volume overload. ASD produces RV volume overload because of the shunting from the left atrium to the right atrium that comes back to the right ventricle, and from that it has to go to the pulmonary circulation. But VSD is not a condition that produces RV volume overload. Then, like MR, you can say TR on the right side, tricuspid regurgitation. Like AR on the left side, you can say PR on the right side. That's all. Pulmonary regurgitation. So forceful, sustained, heaving type of apical impulse. So where you are going to see whenever there is a significant right ventricular hypertrophy, same like what we said for the left ventricle. So here the mechanism is volume overload. Here the mechanism is going to be right ventricular hypertrophy itself. So whenever the right ventricular pressure is very high, so you can see this. So what are the conditions that's going to cause? Any condition that produces pulmonic stenosis. Okay, pulmonic stenosis can be valvular, or pulmonic stenosis can be infundibular, like in TOF. But remember, in TOF, generally right ventricular pulsations will not be seen. Why? Again, because of the VSD. Because there is VSD, I mean, even though the pressure, even though there is a stenosis, the blood will be pushed towards the left side. So the right ventricle need not generate such high pressures, because the VSD itself helps shunting that pressure towards the left side. So only if the pressure is building up within the right ventricle, you will be able to see the pulsation. Here the pressure is dissipated towards the left ventricle, so you will not be able to see the pulsation. So valvular stenosis generally will produce a parasternal heaving or a sustained lift in the third to fifth intercostal space. Third to fifth intercostal space. Whereas in infundibular stenosis, typically it will produce lift in the fourth and fifth intercostal space only. It will not produce lift in the third intercostal space. That's one small difference between valvular stenosis and infundibular stenosis. Then there is an entity that will be used in congenital heart disease. That's called a silent parasternal area. So what is called, what are the conditions that produces no pulsations at all? Silent parasternal area. So these conditions will affect the right ventricle directly. One is Epstein's anomaly. Okay, next is tricuspid atresia, where the blood is not going into the right ventricle at all. Yes or no? Number 3, hypoplastic left heart syndrome, right heart syndrome. I think you can understand. In hypoplastic right heart syndrome, you will not have what? Right ventricle at all. Right side structures itself will be hypoplastic. So these are the conditions where you might have a significant pathology, but a completely silent parasternal area. The patient will suffer from so much of issues, but right ventricular area will be extremely silent. That's all. And generally speaking, one more important thing I want to say, whenever there is a volume overload, hyperdynamic ventricle or hyperdynamic apical impulse, S3 is very, very common. Okay, I told you S3 is a sound that comes because of what? Volume overload. Whenever there is a sustained or heaving type of apical impulse, S4 is something that you see very commonly. fourth heart sound. That's very, very common. S3 in patients are having hyperdynamic apical impulse and S4 in patients with heaving apical impulse. And sometimes S3 and S4 can happen together also, because ventricle can be both hypertrophied as well as volume overloaded. So S3 and S4, that's called a quadruple gallop. You can see all four sounds. S1, S2, S3, S4. Similarly, if the right ventricle is overloaded, you can see a right ventricular third heart sound. Similarly, if the right ventricle is hypertrophied, you might be able to look at right ventricular fourth heart sound in auscultation. I should not comment here because we are talking about palpation. So it's more obvious in auscultation only. But please understand, S3 and S4 can be palpated as well. A palpable S3 is always pathological. Palpable S3 is almost always pathological. It indicates a heart failure. So that's the idea. And how will you grade this parasternal pulsations, parasternal heaving? So there is MCOMS grading. MCOMS grading of parasternal pulsations are there. So you have three grades: grade 1, grade 2, and grade 3. Grade 1, visible but not palpable. Grade 2 is visible and palpable. Grade 3 is also visible and palpable. But what is the difference between grade 2 and grade 3? Grade 2 is something that can be obliterable, which means with your hand pressure, you can obliterate the pulsation. But in grade 3, it will not be obliterable, which means you cannot obliterate the pulsations no matter what. Even if you try to obliterate the pulsations, you will not be able to do that. That is not compressible by counterforce that you give. And generally, grade 1 will be there for approximately only 1/3 of the systole. Grade 2 will be more than 50% of the systole. And grade 3 will be throughout systole. Throughout the systole. Do you understand? Yes. So, I mean, these are just definitions. These are MCOMS grading for parasternal heaving because of right ventricular hypertrophy. And one more concept I want to say is this concept of medial retraction, lateral retraction. So what do you mean by the term medial retraction and what do you mean by the term lateral retraction? And remember, this is very, very important in patients who are suffering from congenital heart disease. Because in congenital heart disease, in clinical examination, you need to comment on whether the apex is right ventricle or whether the apex is left ventricle. So for that, you need to understand the concept of medial and lateral traction. With that only, you will be able to say for certainty that it's a LV apex or RV apex. So what is that? So first of all, I told you the right ventricle is the most anterior chamber. Left ventricle is posterior. Little, not the most posterior. The most posterior chamber will be left atrium, of course, based on anatomy. So first right ventricle, then little behind is left ventricle, then right atrium, then the last posterior most structure is the left atrium. That's how the heart is arranged. So if the left ventricle hypertrophies, generally it just grows outwards, that's all. Nothing much. But if a right ventricle hypertrophies, that also grows towards the left only. Because right ventricle is something that cannot move towards the right side. It can grow only over the left ventricle because left ventricle is a little posterior and you have space. So right ventricle generally grows anteriorly and towards the left side. So sometimes it can overshadow the left ventricle itself. So that is one point that you need to know. Second, what causes retractions? Remember, I told you whichever ventricle forms the, dominant ventricle, that will produce that rotation and that's going to hit the chest wall. That's going to produce the pulsation. Whichever ventricle that is not dominant in a disease, that's going to retract back. So normally, if you see in a normal person like you or me, it's the rotation is like this. For example, if the heart is like this, from my angle, view from my heart. So I told you the heart will rotate slightly anteriorly and towards the left. So that's why you get that apical impulse where even the right ventricle is here, the left ventricle is the one that's coming and hitting the chest wall because of this movement. So the right ventricle is actually contracting. It is pushed back. Okay, that is because of the left ventricular force is more. That's creating a momentum slightly towards the left compared to the right ventricular force. That is why you are seeing a movement like this. So what really happens in the chest wall is your left ventricle will come and hit, and that's called as a positive apical impulse, and slightly medial to the left ventricle, okay, your chest will appear as if it's moving inward because of the movement of the right ventricle backwards. And at the same time, right ventricle is also contracting, that pushes the chest itself slightly inward. So this phenomenon is what we refer to as something called as medial retraction, as you can see here. So what do you mean by the term medial retraction? Medial retraction means you see the apical impulse denoted by plus, but the area medial to the apical impulse will appear as if it's moving inward. This can be seen in very thin patients like pediatric patients. That's why I told you this should be utilized only for patients with congenital heart disease, where they'll be basically very thin, number one, pediatric patients. Second, because of heart disease, they'll be failure to thrive and they cannot gain weight. So it's very easy to see technically in pediatric patients. Don't comment this on adults. If they ask, say, this is how I find, but because patient is very obese, it's very difficult to notice. But in pediatrics, congenital heart disease, where there is failure to thrive, where the child is very thin and malnourished, you will be able to visualize this. So that's why I told you here, if you see, the left ventricle is the one that's forming the apical impulse here. So it's coming and hitting the chest wall, causing the apical impulse, but the right ventricle retracts inward, causing a sort of medial retraction. But on the other hand, if you talk about the right ventricular apex, suppose if right ventricle is significantly enlarged or hypertrophied, what happens is, as I told you, it moves towards over the left ventricle, and the left ventricle goes even more posterior in this situation. Now, which force will be more in a significant right ventricular enlargement? Right ventricular force or left ventricular force? Right ventricular force. Now, because of left ventricular momentum, the heart rotated like this. Now, in this situation, because the right ventricle is the dominant force now, the heart will start rotating in the opposite direction. So the momentum can be right ventricle is more, so it will start shifting like this in a different direction. So your apical impulse will come and hit in the parasternal region. That's where you see the pulsations and the apical impulse. So that's why it's denoted as plus here. Okay, this is where you see the apical impulse. Do you understand? But because the left ventricle is more posterior and the heart is moving relatively in a different direction, left ventricle is retracting posteriorly, lateral to the apical impulse, the chest will appear as if it is retracting. So this is what we called as lateral retraction. This is what we called as concept of lateral retraction. Very simple concept. So technically speaking, if it's a medial retraction, it's a LV apex. If it's a lateral retraction, it's an RV apex. So you are going to compare where the maximal impulse is and which area it is retracting. So where it is hitting and where it is retracting relatively. So if the retraction is medial to the hitting area, that is medial retraction, LV apex. The retraction is lateral to your apical impulse, then it's a lateral retraction, very likely to be a right ventricular apex. There is another concept also called as median retraction, not medial, median. First I told you medial, now I'm telling median retraction. So what is that? This happens in patients with biventricular hypertrophy, which is also very characteristic in conditions like VSD, ventricular septal defect. There's a biventricular hypertrophy. There will be two apical impulses. Okay, so you will get parasternal pulsations also, you will get LV pulsations also, very dominantly. They may be codominant, okay, because both ventricles are enlarged in this situation. So you will get retraction in between, that is due to retraction of interventricular septum. The only thing that goes backward and retracts the chest is interventricular septum. So you will get two beats, okay, two impulses with an in-between retraction. That's what we refer to as a median retraction. So examiner may not torture you with so much evidences and all, but they will ask you how to find out at least. This is a realistic way to find out whether it's a LV apex or RV apex. But in certain conditions, you will be really able to see. For example, in ASD, most of the times it will be RV apex. because of significant right ventricular enlargement and hypertrophy sometimes. So that in that situation, all you need to comment it's an RV apex. If they ask you why it's an RV apex, you should say it is a lateral retraction. That's why I'm saying it is RV apex. And there's a predominant pulsation in the parasternal area, but the lateral to the parasternal area, it appears to be retracting. So that's why I'm commenting that it's the right ventricular apex. So you need to substantiate like that. So medial retraction, left ventricular apex. Lateral retraction, RV apex. Median retraction, suggestive of biventricular hypertrophy. Okay. So these are very important concepts. How to find out what is the apex. And next is going to be the arterial pulsation. So now we have commented on apical impulse and the apex itself. Now comment on arterial pulsation. Okay, arterial pulsation is the same. Okay, in the same, either you're going to look in the left upper sternal border, right upper sternal border, depending on whether it is pulmonary artery pulsation or aortic pulsation. Okay, like what I said for inspection, the same appears true here also, but you have to comment in palpation, that's all. If there is any palpable arterial pulsations. Then there is another sub-concept called as tracheal tug. Tracheal tug. Which is also referred to as something called as Oliver's sign. Oliver's sign. Otherwise called as Oliver's tracheal tug. So how will you perform a how will you look for a tracheal tug if it is present? So, no need to do all these things, tracheal tug and all. Standardly, I've seen students commenting on tracheal tug every time. There is no tracheal tug. So remember, only if you encounter a aortic pulsation, right upper sternal border pulsation or right sternoclavicular joint pulsation, which is prominent, means then only you have to perform tracheal tug, because it's a sign that will be positive only in patients with significant aneurysmal dilatation of the aorta. So whenever there is significant aneurysmal dilatation of aorta, sometimes it can, with each pulsatile, because it's an aneurysm, it might have communication with the bronchus. It's not communication in the sense, not opening, touching the bronchus. So because it touches the bronchus, with each pulsation, it might pull the bronchus along with the trachea down. So when you go behind and you palpate the trachea from behind, you might see the trachea is moving down with each beat, each systole. So this is what we call as tracheal tug, or this is what we refer to as Oliver's sign. So let me see whether it is there or not in my presentation. I think I have not mentioned. It's not there. Okay. Anyway, I'll try to show the image how to examine, but that's how you examine. From behind, you just, very simple. I think you do not need to see also. Just keep the fingers here. The trachea moves down in a pulsatile fashion with each beat. That's considered to be significant for aortic aneurysm, aneurysmal dilatation of aorta, and that's what we call as tracheal tug. And next, you have to look for palpable heart sounds. Okay, palpable heart sounds. Remember, any heart sound may become palpable. Any heart sound may become palpable, depending on the underlying pathology. For example, in MS, your first heart sound may become palpable. Similarly, in aortic stenosis, your second heart sound, not aortic stenosis, systemic hypertension, your second heart sound may become palpable. A loud A2 may be there in hypertension patients. Similarly, in pulmonary artery hypertension, your P2 may become palpable. Similarly, in significant left ventricular failure, S3 may become palpable, or even S4 may become palpable. So you have to comment on the palpable heart sounds. Okay, depending on the underlying pathology. So what we are discussing with, if it is there, then it becomes very significant. Okay. And if P2 is one important entity is, if P2 is palpable, suppose if you are able to palpate the second heart sound, that is P2, the pulmonary component. Remember, pulmonary component is best palpated in the pulmonary area. Even in pulmonary hypertension, only in pulmonary area you will be able to palpate. Maybe sometimes people say you can palpate in the apex also. So let me tell you some clues with regards to that. Let me take a chest, maybe on chest will be helpful. So first let me tell where the aortic sounds will be palpable. Whenever A2 becomes palpable, because second heart sound has two components, A2 and P2. So if A2 is palpable, generally it will be palpable in a wide area. It will be palpable in the aortic area, it will be palpable in the pulmonary area, it will be palpable in the apex, but not in the left lower sternal body generally. But apex, pulmonary area, as well as aortic area, you will be able to palpate second heart sound if A2 is palpable, if A2 is the one that becomes dominant. On the other hand, if P2 is palpable, then you will be able to palpate P2 only in pulmonary area predominantly, or probably in the apex. P2 is never palpable in the aortic area, even if the pulmonary hypertension is very severe. That is the take-home point. Okay or not? So whenever P2 is palpable, that is pathognomonic and definitely confirms it's a pulmonary hypertension. That is the inference of that. P2 palpable means it's pulmonary hypertension only, for sure. Okay, then next thing you have to look for atrial impulse. Atrial impulse. So what is the difference between atrial impulse? Also will be seen in the parasternal location only. But what is the major difference between atrial impulse, atrial pulsation, and your right ventricular pulsation? Because both will be visualized in the parasternal area only, near the parasternal area. What is the difference? Atrial pulsations will be seen during the ventricular diastole, whereas ventricular pulsations will be seen during the systole. That is the major difference, nothing much. Do you understand or not? Atrial pulsations very commonly will be seen during the ventricular diastole, because atrial contraction is also happening during the ventricular diastole only. So especially if you see the pulsations in the late part of the ventricular systole, ventricular diastole, then it suggests it's an atrial pulsation. So that's the only way to differentiate between atrial and ventricular pulsation. In certain situations, it might become very significant, especially in patients with mitral stenosis. The left atrium may be huge, and we call it as aneurysmal left atrial dilatation, huge left atrium in MS. So in that situations and all, you might encounter a left atrial pulsation. So you need to comment on that as well. And apart from that, you can comment on these things if there is any special situations like inward retractions. I told you already, inward retractions can be appreciated as well in two situations. One is constrictive pericarditis and second is tricuspid regurgitation. In these two situations, you can comment on inward retractions. I told you in the inspection finding itself. Next, thrills, finally. What are thrills? Thrills are palpable murmurs. That's all. These are thrills. So remember, only if the murmur is grade 4 and above, then only you will be able to palpate. Then only thrill will be present. Don't say in exam that the murmur grade is 3 and then say thrill is also there. It is like contradicting your own statement. Thrill will be there only if the murmur grade is 4 and above. Presence of thrill indicates severity. True statement or false statement? Palpable thrill. No, thrill has no clinical value. Okay, it is not going to correlate with severity. But one clinical value you can say is in a diastolic murmur, thrill has a clinical value in the form of telling that it's an organic murmur for sure. Because there are functional murmurs and organic murmurs. Functional murmurs are innocent murmurs. But on the other hand, you also have to know that functional murmurs will never cross grade 3. So if there is a thrill, it cannot be a functional murmur, especially if it's a diastolic murmur. If it's a diastolic murmur, or if you have an associated diastolic thrill, that confirms the organicity of the murmur, which means it's surely due to some pathology, not a functional murmur, not just a flow murmur. There is some real problem existing in that area. Apart from that, presence of thrill will not tell any severity. That's very, very important. Okay, it has absolutely no clinical value apart from the fact that diastolic thrill can correlate with organicity of the disease. That's all. Okay. Now, how to differentiate between some small theory point? RV apex versus LV apex. Remember, LV apex will be more localized, as I've told you. Whereas RV apex will be diffuse and widely palpable over a large area. And RV apex most of the time will be continuous and synchronous with right parasternal pulsations. It will be diffuse as well. Okay, it will be seen in a wider area. As you can see, I told you one method, no, how to palpate right ventricular pulsation. With 3 fingers, you are palpating. Naturally itself, you are palpating with what? 3 fingers, and it will be more diffuse in the chest, and it will be synonymous and it will be synchronous with the right parasternal pulsations. And it will be continuous with the parasternal pulsations. What type of retraction you will see in the LV apex? Medial retraction. Whereas in RV apex, you will see lateral retraction. And this kind of retractions are best appreciated in what position? Supine or left lateral position? Obviously left lateral position. Okay, that is why in any pathological states, examine the patient in left lateral position, decubitus position. Never examine supine position. What are the examples where you can see an RV apex? Okay, so any condition that produces right ventricular volume overload. For example, you have something called transposition of great vessels, then tetralogy physiology. So there is an umbrella term called tetralogy physiology where many diseases will come under one single area. So in all these situations, you might be able to see a RV apex. Where let's say LV apex, where right ventricle is not dominant, like tricuspid atresia, where right ventricle is not at all dominant. Single ventricle, but it's a left ventricle. Okay, single ventricle situation. If you have a Epstein's anomaly, where right ventricle is inconspicuous, or if the patient is having pulmonary atresia with intact septum. Usually in this situation, there will be a large ASD, otherwise the patient will die. So that ASD should shunt the blood towards the other side. So pulmonary atresia with intact septum means what? Whatever RV tries, it cannot do anything because there is no pulmonary vessel to go, and it's an intact septum situation also. So there should be an ASD that shunts the blood from right side to left side on the top itself. The blood is not even coming to right ventricle because of high resistance. Blood knows, so it goes directly from right side towards the left side. It's a cyanotic congenital heart disease, of course. And probably I can say double outlet right ventricle, and other condition pulmonic stenosis, and probably restrictive VSTs. Restrictive VSTs. What do you mean by restrictive VST? A very, very small ventricular septal defect where the shunt is not too great to produce significant pulmonary hypertension and problems. Are you understanding or not? It is like normal, like you and me only, but very small VSD. For namesake, it is there. That's all. Do you understand? Yes. So these are the conditions that generally produces an LV apex. So is there any condition which I've told you with regards to adult disease here? No, I've not commented anything regards to the adult cardiac disease. I've commented only on what? Congenital heart disease. That itself says that you have to use this LV apex, RV apex terms only in patients with congenital heart disease. Please don't use these terms for adult cardiac diseases. You will be completely screwed up in the exam. Okay, never ever comment on that. If they ask you, also like be silent most of the time in adult diseases. But in childhood disease, you cannot, especially if it is cyanotic congenital heart disease like TOF and all, you have to comment on LV versus RV apex. Okay. What are these for? This palpation? Because another thing what we missed in the palpation. These are hepatic pulsations. You can say in the palpation itself. So where will you see hepatic pulsatility? Commonest condition is TR, okay, tricuspid. By theory, at least it is tricuspid regurgitation. Severe tricuspid regurgitation can produce substantial hepatic pulsations because the regurgitant jet back into the IVC back into the hepatic veins. Yes or no? So you can see hepatic pulsation. This is the technique to look for hepatic pulsation. For example, first technique is just normal palpation of the right hypochondrial area. Second technique is using a fist to palpate on the intercostal areas. Okay, you can see a kind of a lift in the knuckle that you have made. You'll be able to see a kind of lift like this. So in the over the intercostal spaces, maybe in the 4th, 5th, and 6th intercostal space here, you can keep your knuckles like this, and you can look for the lift of the hand that confirms that it's a hepatic pulsation. So typical cause of hepatic pulsation is going to be your tricuspid regurgitation. That's all. Then coming to the percussion. So percussion, whether you do it or not, again depends on your local policies. Some colleges say that you don't do percussion. Some colleges ask you to do percussion regularly, cardiac percussion. But it is one of the signs that has absolutely no value in the modern practice. Cardiac percussion. Your pulmonary percussion has a lot of value, but cardiac percussion doesn't have that much value, and the sensitivity, specificity, PPV and NPV values are very poor with regards to cardiac percussion. But at least for namesake, you need to know some information. Okay, so how will you draw the surface anatomy of the heart in the first place? Okay, first location, you have to draw the right heart border, and then you have to draw the left heart border, because this is one common question they used to ask in my college, especially Kerala examiners tend to ask the anatomy of the heart. So they have to ask the describe. I mean, they will ask to tell in the patients to draw in the chest wall itself. They give a marker and ask them to draw. Most of the time they harass like this and all. When they will harass us, they will ask whether percussion is important or not. We will comment like no. If you comment like no, then draw the heart border and draw the heart border for this patient and percuss and tell whether it is, deviated from the normal patient or not. So first, if you draw the normal heart border, then if you percuss, if you say LVH, it's deviated, no, then how can you say it is not relevant? They will argue like that. If you say yes, if it's relevant, no, then draw the heart border. So in either way, they used to harass us by asking us to draw the borders and all. So first, right heart border. Where is the right heart border? You have to take an area in the third space, number 1. I think I can draw correctly here. Okay, let me take the second costal cartilage. Okay, left second costal cartilage maybe here. Drawing correctly only, no? Yes, yeah. It's very unclear here. Okay, so left second costal cartilage. Okay, what area? Approximately like 1.5 inch from the midline. Like 1.5 inch from the midline. That is 1.5 inch from the midline in this left second costal cartilage. Okay, second, you are going to mark a point in the right third costal cartilage, approximately 1 inch from the midline. This is 1.5 inch from the midline, and this is 1 inch from the midline. That is right third costal. Then note the fifth intercostal space. Where is the fifth? This is 1, 2, 3, 4, 5. So this is the fifth intercostal space. You are going to take a 3.5 inch cutoff here and draw another point in the fifth intercostal space from the midline. So this is approximately 3 inch, or maybe say 3.5 inch, 3.5 inch. Then you take the right sixth costal cartilage. So 1, 2, 3, 4, 5, 6. So you have the sixth costal cartilage here, and you are going to draw just a 0.5 inch line from the midline. So from the midline, take a 0.5 inch, half an inch from the midline, and draw another point on the right sixth costal cartilage. So now join all the borders. So this is the normal cardiac border. Join all these things. So what are the numbers that you need to know? Right side, third, left side, second, again right side, sixth, left side, fifth, but intercostal space. Okay. Right second costal cartilage and right sixth costal cartilage, left second costal cartilage, and left fifth intercostal space. Okay, join all these things and form the borders. And inches also will be different. Left for upper sides, it's 1.5 inch on the left and 1 inch on the right. And for lower portion, lower border of the heart, it is 3.5 inch on the left and 0.5 inch on the right. Okay, so these are the numbers. Sometimes you might get confused, but these are you mark the heart, cardiac borders. And how will you percuss basically? Cardiac borders. So to be honest, it's a very tedious process. It's very time consuming process. So you need to percuss from each and every intercostal space. Okay, each and every intercostal space you need to percuss, and not just vertically like this. You need to percuss horizontally also with each intercostal space. Do you understand? With each intercostal space, you have to percuss horizontally as well as you have to come down vertically as well. So when you percuss horizontally in the each intercostal space, at one point you will see a cardiac dullness. A dullness will come. And you turn the finger, that's what it's shown. So as you keep moving towards the left, probably in the fifth or fourth intercostal space, as you keep percussing from lateral to medial, so at one point you will see a dullness, and at that point your finger should become more vertical. So now find out the exact border and draw. Very tedious. Okay, but that's the technique that's been described. This is how you do the cardiac borders. Likewise, you have to do in every intercostal space, and you have to find out the cardiac border. Very difficult, and the problem is the reproducibility of this is very, very bad actually. So you will say one thing, I will say another thing. So this is not a very valid sign. Absolutely abysmal sensitivities and specificities and PPV and NPV for percussion of the heart. So it has absolutely no relevance or value in the current clinical practice, to be honest. And this is the method of how to approximately palpate the borders of the heart. So as I told you, first, you have to start from the upper intercostal spaces, but here I've shown you, for example, we are palpating the lower intercostal spaces. So once you find a dullness at certain point, immediately your hand should be, your finger should become vertical, and using that vertical method, you need to palpate exactly where the dullness is, and you have to find out the cardiac border at each intercostal space and connect everything together and find out the entire cardiac border by percussion. So if they ask you the technique, at least you should be able to say how to percuss the heart. So this is how you percuss the heart. And the patient should be in what position? What position the patient should be in? See there and say. Supine position. That's all. Okay, percussion should be ideally done in supine position. Sitting position, doing this is very, very difficult. That's why we do it in supine position. And there are two signs are there with regards to pericardial effusion, because the entire idea of finding out this cardiac borders is to find out the cardiac dullness that is extending, throughout the borders of the heart or not. In pericardial effusion, not just one border will be out of sorts, like the entire cardiac border will be enlarged. So that is suggestive of pericardial effusion, isn't it? So that's why we have two signs of pericardial effusion. One is called as Rot sign. Okay, ROTCH, Rot sign. So what Rot sign means is, in the right fifth intercostal space, okay, right fifth intercostal space, if the dullness extends more than 2 to 3 centimeter from the parasternal region, is suggestive of pericardial effusion. That's what he said. That's called Rot sign. Okay, if the dullness extends more than 2 to 3 centimeter from the parasternal region, on the right side, of course. That's called as Rot sign. And later on, there is another sign that's been described that is called Morris sign. What Morris sign said is, it's not on the lateral extension. In pericardial effusion, there will be a superior dullness also. That is understandable. It's not just on the lateral side, that like what we are palpating, it should extend on the superior side also. So he said the dullness should be there in both right and left upper intercostal spaces. Upper intercostal space means we are talking about second, probably the second intercostal space. Even in those areas, the dullness will extend more than 2 to 3 centimeters from the parasternal region. Parasternal region. So this is what we call it as Morris sign. Both are understandable because I told you the entire cardiac border is going to become big if it's going to be a significant pericardial effusion. Are you understanding or not? Okay, that's all. So this is all about your percussion. So whenever they talk about percussion, the relevance is only with pericardial effusion. Whenever you talk about pericardial effusion, only two signs should be noted. One is called as Morris sign and second is Roth sign. That's all.